Hello everyone. Today I'm going to cover the topic pneumothorax, which has been repeating from last 6 months into 2026. Okay, so yeah, let's start. Okay, how to approach the primary pneumothorax, a primary spontaneous pneumothorax. First, we will learn that, and then we will learn how to differentiate primary from secondary, and then traumatic one. Okay, so let's start quickly. So how to approach the primary spontaneous pneumothorax? I took this from therapeutic guidelines. Okay, primary spontaneous pneumothorax confirmed on say chest X-ray or CT. Okay, give adequate analgesia and oxygen if hypoxemia. Does the patient, and then we have to ask that, does the patient have any signs of clinical instability, systolic blood pressure less than 90, tachycardia, tachypnea, hypoxemia, severe chest pain, unable to mobilize, or breathlessness? Okay, so if no, then we have to observe for 4 hours. That is very, very important. They have been asking like from last 6 months. Okay, if the patient is clinically stable, then what we are going to do, we just observe the patient. Okay, just observe for 4 hours. Then patient remains clinically stable, then ensure the patient, okay, we will read this. Ensure the patient able to seek medical attention if deterioration occurs. Discharge with advice to represent if symptoms reoccur. Review chest x-ray every 2 weeks until resolved. Okay, every 2 weeks until resolved. Refer to respiratory specialist if pneumothorax does not resolve within 8 weeks or if recurrent. Okay, the thing is, if the patient comes to you primary or secondary, if the patient is clinically stable and patient don't have any symptoms, then we have to observe the patient, admit the patient and observe for 4 hours. Observe the patient for 4 hours, don't forget that. Observe the patient, just see that, okay, if the patient is stable, they don't have any shortness of breath and patient is fine. Okay, the patient just have only a mild chest pain, pleuritic chest pain, don't go for what you call the interventions. Okay, just observe the patient for 4 hours, admit the patient, observe the patient, right? And then if the patient is remains stable, then what we are going to do, discharge with advice that if your condition will be deteriorate, you have to come immediately to the hospital. Discharge with advice to represent if symptoms reoccur every 2 weeks until the pneumothorax is resolved. And if this pneumothorax does not resolve, like with any reasons, then what we're going to do it, we have to refer the patient to the respiratory specialist. Okay, if pneumothorax does not resolve within 8 weeks or if recurrent, refer. If cannot, if the pneumothorax will not resolve within 8 weeks, refer the patient. Okay, during the observation, if the patient is clinical and unstable, that is very simple. We have to take the intervention. We have to do the intervention, right? So very simple. Okay, if the patient is symptomatic, then what we are going to do? We will do the intervention. Okay, in case of emergency, when the patient has tachycardia, tachypnea, hypoxemia, saturation is 90 or 89, and severe chest pain, then definitely what we are going to do, that we have to decompress, right? So we will do the needle thoracostomy. Okay, catheter aspiration means needle thoracostomy, and intercostal catheter drainage, it's the same thing, drainage. Okay, does the patient have any of the following features requiring further management? No lung reinflammation, inflation, persistent ear leak, symptoms not resolved. What it mean? Okay, you will do the needle thoracostomy. Okay, and the patient somehow not really stable. Okay, patient has still the symptoms, then you will do the drainage, right? Chest tube drain. And then if the patient is still unstable and the patient is vitally unstable, still thickening, tachycardia, okay, chest is not inflate, then what we're gonna do it, we have to check the chest tube. Okay, uh, uh, most of the time whenever we do the chest training, we have to perform the x-ray just to confirm that the chest tube is in the place where the pneumothorax is. where the air is trapped. Okay, so we have to make sure that chest tube drain is fine. Okay, if it's not, then we have to refer the patient. Does the patient have any of the, as we already discussed? If yes, patient has no lung reinflation, persistent air leakage symptoms not resolved, then inpatient admission with intercostal catheter drainage and underwater seal. If not used initially, then we have to do the drainage as I discussed earlier. Okay, if the patient don't have any of these symptoms, like means the patient is stable, observe for 4 hours and repeat chest x-ray. 4 hours, repeat chest x-ray. Lungs re-expanded and the symptoms have improved are resolved. If yes, then we have to advise this one, right? If no, then we have to refer the patient, right? Okay, understand? This table, if you learn this table, definitely you will get through all the questions. Not all the questions, almost 70% you can get all the questions. Okay, so how we diagnose the pneumothorax? Diagnosis is confirmed by imaging techniques, as we read that X-ray and CT. CT is confirmatory, but imagine that if patient comes to you, just think as a clinician. If the patient comes to you with tachypnea and low blood pressure, hypotensive, patient is not stable, you are not going to perform the test, right? But only one test in the emergency department will do the ultrasound, e-fast, right? Just to quickly get to know that. So in cases of emergency, first of all, for tension pneumothorax, we don't need any test. We don't want to waste our time. We just clinically diagnose the patient and just do the intervention. But if in during the exam, if they ask about the initial investigation, in case of tension pneumothorax, we can do the ultrasound, right? Okay. Bedside ultrasound, more sensitive than X-ray and rapidly available at the bedside, will demonstrate the absence of lung sliding, loss of wave on the beats, sign on M mode. Standard erect inspiratory PA X-ray. If we need to in what you call the pneumothorax, we will do this X-ray, right? CT scan is recommended for uncertain or complex cases. So remember that initial investigation is X-ray, but in tension pneumothorax we will do the fast ultrasound, right? Bedside ultrasound. Standard erect inspiratory. Remember that inspiratory. If we will do the X-ray in inspiratory, so we just expand the pneumothorax, and we will be the size will show a bit more. So that is why we will never rely on expiratory. We will always rely on inspiratory. Okay. So let's go through the topic. All these things is from therapeutic guidelines, right? Pneumothorax, presence of air between the visceral and parietal pleura, air in the pleural space, and lung collapse. So just go through these, and then you can answer 100%, like all the questions you can answer it if you are clear with the concept. Classification, it classified as spontaneous pneumothorax and spontaneous, and the other one is traumatic pneumothorax, iatrogenic pneumothorax. Okay, there are 3 classifications. Traumatic, we know that by the name. Spontaneous pneumothorax. Spontaneous has 2 further types, primary and secondary. Secondary one is that those patients who has some like underlying diseases like COPD. COPD is the most common cause of secondary spontaneous pneumothorax. And in spontaneous pneumothorax, patient is like fine, patient don't have any underlying diseases, no underlying lung disease, common in young patient, tall, thin individuals, classic, right? Patient don't have any symptoms, nothing. Okay, most of the time athletes and not athletes, is football players and anything. In the scenario, they are asking about the football players. Spontaneous secondary, it's because of the COPD. COPD is the most common cause, asthma, interstitial lung diseases, and cystic fibrosis. Okay, asthma, interstitial lung diseases, cystic fibrosis. And I also saw in e-medicine there are also one condition, Marfan syndrome. Connect. Marfan syndrome, they are also leading secondary pneumothorax. Okay. Traumatic, it's clear with the name. Traumatic because of trauma, causes are blunt trauma, penetrating chest trauma. Iatrogenic pneumothorax because of the during the medical procedures, and in the e-medicine they are talking about central line insertions, procedures involving pleura. Okay, lung biopsy, so keep remember that. Okay, what is the clinical presentation? Very, 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 very important. Typical spontaneous pneumothorax, sudden onset pleuritic chest pain, breathlessness. Okay, and diagnosis is through history and inspiratory chest x-ray. Avoid expiratory chest x-ray because it may exaggerate pneumothorax size, as I told you earlier. CT scan, consider when the patient cannot sit upright, spine x-ray difficult to interpret, coexisting lung diseases. Okay, in that cases we will do the CT scan, otherwise we will only rely on x-ray. And in cases of emergency, tension pneumothorax, we will do the fast, right? Physical signs for large pneumothorax: breath sounds are decreased, tachypnea, chest wall movements are decreased, hyporesonance on percussion and vocal resonance decrease, vocal chest wall movements are decreased, breath sounds are decreased, tracheal deviation away from the affected site, large pneumothorax. In a real AMC exam, they are going to give us all the signs, but remember, hyporesonance they are giving from last every single time they are giving this hyporesonance on percussion, and decreased chest wall, tachypnea, all the signs are like from all these. They are keep asking about they are giving us the clue on hyporesonance on percussion, right? Other one is tension pneumothorax, rapidly developing large pneumothorax causing clinical instability. It's a medical emergency, right? Features severe breathlessness, hypoxemia, hypotension, cardiovascular collapse. Tracheal deviation, reduce air entry and respiratory distress. Reduce air entry, remember that. Tracheal deviation and reduce air entry. It's an emergency. In that emergency, you will not perform the X-ray. If you really want to go for one investigation in tension pneumothorax, in cases of emergency, we will do the fast ultrasound, right? Otherwise, we don't need. It's a clinical case, so it's just based on the history and clinical examination, we can do the intervention. Diagnosis, clinical diagnosis. Do not wait for imaging, please. Management, emergency, urgent needle decompression, and after urgent needle decompression, you have to do the intercostal catheter drainage. That is the rule. Urgent needle decompression, and then after that intercostal catheter drainage. Mediastinal shift alone does not mean tension pneumothorax. Needs clinical deterioration and instability. Very, very important from therapeutic guidelines. Positive pressure ventilation risk. Patient on CPAP, BPAP, mechanical ventilation can deteriorate rapidly if pneumothorax develops. If sudden deterioration occurs, consider decompensated pneumothorax. What is decompensated pneumothorax? Decompensated pneumothorax is it's another name of tension pneumothorax. So don't be confused. But remember that if we really want a patient on blunt trauma or injury, and if we want to put a patient on what you called on CPAP and BiPAP, we have to do the what you call the chest tube drainage. We have to put the tube first, and then we can put the patient on CPAP, BPAP, and okay, understand? Very, very, very important point. And mechanical ventilation, whatever. Okay, remember that if we patient has a pneumothorax, or even patient don't have pneumothorax, and we put that, we give the 100% oxygen. So sometimes uh, the because of high positive peak pressure, patient will get the pneumothorax. So during that, always remember the patient on CPAP, BPAP, or ventilators, and patient is immediately deteriorated with decreased breath sounds, hyperresonance, go for pneumothorax. Okay, tension pneumothorax. Primary spontaneous pneumothorax thorax management. Remember that. Before that, we have to measure the size, and then the management depends upon the size of the pneumothorax as well as the clinical presentation of the pneumothorax. But now, don't focus on size. Remember that. If patient is clinically deteriorating, the patient is vitally not stable, we have to do the intervention. And the early intervention is that if the patient is like completely vitally stable, hypotension is in shock, patient is in shock, then we have to do the needle thoracostomy. Okay, But if the patient comes to you with a saturation is around 94%, the patient is in pleuritic chest pain, what you gonna do is you have to give the painkiller and oxygen. Okay, don't jump on that what you call the interventions. Remember that. Remember, patient, if patient is stable, vitally stable, blood pressure is okay, everything is okay, patient is fine, no need to do the any intervention. But if patient is deteriorating, hyperresonant, like symptomatic, then go for it. Go for it. Don't think about the size. Oh, size is not, size is less than 1 centimeter, 2 centimeter, whatever the size is. The patient is symptomatic, we have to do the intervention. If the patient don't have any signs, any symptoms, even in tension pneumothorax, most of the time in tension pneumothorax we do have symptoms, right? So uh, otherwise we have to do the intervention if the patient is symptomatic, either it's primary or secondary one. But remember that in secondary pneumothorax we will always do chest drain. We will always do the chest drain. Always. So all primary spontaneous analgesia and oxygen if hypoxemic, many can be managed conservatively. Okay, if in the scenario the patient is widely stable and not really in pain, then which option we have to choose? Observe for 4 to 6 hours. Admit the patient and observe 4 to 6 hours and repeat the X-ray. Conservative management appropriate if the patient is stable. So it's primary, secondary, these are the differentiating table. I think we already know that. Okay. Pneumothorax diagnosis, inspiratory X-ray, do not use expiratory tension pneumothorax. The clinical diagnosis, unstable patient, needle decompression. Stable primary pneumothorax, conservative management initially. Observe 4 hours, painkillers, oxygen. Initial management, all patient analgesia, oxygen. Given only if hypoxemia, pain attributes significantly to breathlessness, treat pain first. Okay, what does it mean? That okay, sometimes because of the severe pain, patient comes to us with breathlessness, right? So treat the pain first. Okay, very important point. Understand the concept. When to intervene. Consider clinically unstable patient. In clinically unstable patient, we have to do the pleural intervention. Catheter aspiration, that is the same. Needle decompression, intercostal catheter drainage, ICD, chest tube, all words the same. Okay, drainage has risk. Yes, definitely when we do the drainage, it has organ injury, bleeding, and infection. That is, but that's not important. Recurrence of primary spontaneous pneumothorax. If the patient comes to you like after with 2 weeks or after 8 weeks with the recurrence, as I told you, according to the table, we have to refer the patient. Risk is 30 to 50% risk in recurrence. Risk increased by continuous smoking. Okay, remember that we have to avoid. We have to advise the patient that stop smoking. Smoking cessation advice is very important. Recurs in the same lung. Refer for pleurodesy. Then we will refer the patient for pleurodesy. What is a pleurodesy? In the lungs, we put some chemicals on the outer surface, and then the fibrosis built, and then somehow we just close the what you call the space. Okay, so just work on that. What is pleurodesy? You will come to know. You can watch the video on YouTube. Pleurodesy options include medical thoracoscopy and talc, Watt's pleural abrasion, talc slurry through intercostal catheter. It's just a chemical they put it just to give the irritation, and then our lungs will produce the fibrosis, and then somehow it's work. But it's really painful. Secondary spontaneous pneumothorax, as I told you, COPD is the leading cause. Okay, in initial management, I told you in secondary pneumothorax we have to do the chest training because the lungs is already compromised, so we don't want any the observation or anything. We just directly jump on chest tube. Analgesia, oxygen if hypoxemic compared with primary spontaneous pneumothorax, most likely to need hospital admission and early pleural intervention. Okay, treatment usually it's not about 100%, but like 90% intercostal catheter drainage, chest drain, right? Catheter aspiration like less likely to succeed because the patient lungs is already compromised, right? So that is why we have to do the like chest tube drainage. Do not put untreated pneumothorax patient on CPAP. Bypass positive pressure ventilation can rapidly worsen pneumothorax. Iatrogenic medical procedure trauma, as I told you, example pleural aspiration, transbronchial biopsy, percutaneous lung biopsy. It gives us the pneumothorax, but it's really small, resolve spontaneously. Sometimes we have to do the observation if needed, catheter aspiration. Urgent needle decompression in hypertension pneumothorax, the patient is severe bladder sickness, hypoxemia, hypotension, cardiovascular collapse. Clinically diagnosed, do not rely on any other test. As we know that we have to, how we will do the needle thoracostomy above third rib, means second rib. Remove needle, insert thoracostomy tube as soon as possible. Okay, yeah, that is the procedure, but that is not important at all. But yeah, if you want to read it, you can read it. Intercostal catheter draining, chest is chest tube. What is the indication of chest tube? Very important. Failed catheter aspiration in primary spontaneous pneumothorax. Okay, if the patient comes to you, you did the what you call the early intervention, like needle decompression, but the patient is still not stable. Then you have to do the chest tube drainage, right? Failed catheter aspiration, right? Secondary spontaneous pneumothorax, unless small and stable, we will have to do the chest tube drainage, scanning pneumothorax. But they also mention that unless small and stable, then we don't need to do it. Unless small and stable, traumatic pneumothorax, unless small and stable, we have to do that, right? After needle decompression for tension pneumothorax, that is, as I told you, in tension pneumothorax, we always do the needle compression, decompression first, and then we will do the chest tube drainage, right? That is not important. We already did that. Stable anesthesia, oxygen, conservative, unstable, catheter aspiration, ICD. Recurrent pleurodesy referral. Secondary one, ICD, most tube, chest drainage admission. Iatrogenic small, observed tension, needle decompression, and then chest tube. Untreated pneumothorax plus CPAP, BPAP, avoid. We have to avoid. If we really want to put that patient, then we will do the chest tube first. Secondary drain, early attention, decompress immediately, trauma, chest tube usually. Okay, so that's ultrasound image. I took it from what you called, I always forget the name, I'm really bad in Videopedia. Okay. So in ultrasound, what we will observe that there is this line is actually in most of the time, like not in most of the time, always, it just shows a sliding line, like it just slide moving forward, move forward. But in that pneumothorax, absent lung sliding, absent lungs are not sliding. So that is the diagnosis for pneumothorax. So through scan we come to know that, because this line which you can see, it just slide, it just keep moving, okay. But in case of pneumothorax, it's not moving, it just static, it just stays, okay. And can you see this chaotic movement? It's muscles, it's these are the muscle layer and the layers, and these are the ribs and the ribs reflection, and here we can see the air, and yeah. So in X-ray, how we can see that? Okay, we will see these are the visceral pleural edges. We can see these are the visceral pleural edges. These are the visceral pleural edges. As you can see, the visceral pleural edges, right? And then free air. This area is very dark as compared to this one. And then collapsed lungs. So these are our lungs. As you can see, the dark area, just like the just compressed, congested one, right? So this is our lungs, the congested one, the darker one, and mediastinal shift. So it's just mediastinal shifting is here, just like this way. Okay. Mediastinal shift, collapsed lung, mediastinal shift. You just go through that. Okay. Let me double it so you can clearly see that. Okay, lungs are collapsed, visceral pleural edges, visceral pleural, we can clearly see. Free air is very dark as compared to the other one, okay. And the collapsed lungs, this one is a collapsed lung, right? And this one, mediastinal is shifting. Okay, as you can see in this x-ray. So where is the lungs? Oh, I'm not really sure in this x-ray. It looks whitish. I'm not sure about this x-ray. I think this one is the marking. Hmm. Not really good x-ray. I'm not really good in x-rays, honestly. If anybody knows, just please let me know. Okay, this image I took it from e-medici, I guess. Okay, so here is the lung marking, as you can see, the compressed one, right? And mediastinal shifting, here we can clearly see the mediastinal is bit shifting. Okay, good. Okay, as we already discussed, CT is the gold standard. Thoracic ultrasound has higher sensitivity as compared to X-ray. Pneumothorax, after blunt trauma, we can use the ultrasound and can be used at the point of care. Okay, let's do some past recall question, not just few. I have a lot of recall question, not a lot, but at least from last 1 year, I have these recall questions regarding the pneumothorax. Okay. A 16-year-old or 20-year-old, okay, in one scenario they ask about 16 and then in the other scenario they ask about a 20-year-old. So just quickly answer it. First of all, we just go through that. If the patient is clinically stable, no need to do any intervention. Patient stable, nothing. If the patient is clinically deteriorating, don't look at towards the size 2 centimeter, 3 centimeter, 15% or whatever percentage. We have to do the intervention. In tension pneumothorax, first we will do the needle decompression, then we will do the chest tube drainage. Okay, and after that, if the patient is stable, we are not going to send the patient. We have to wait for 4 hours, 4 to 6 hours, observe the patient, do the scan, and then do the x-ray, and then advise the patient that if patient is clinically deteriorating, patient has to come again in the clinic, and then after 2 weeks we will repeat the scan, and after it we will have to do 2 weeks until the pneumothorax will resolve. If the pneumothorax will not resolve within 8 weeks, we have to refer the patient. Same goes to other. If the patient is clinically unstable, we will do the intervention, right? Okay, let's solve the question on that simple basic concept. 16-year-old male patient presents with sharp chest pain after playing volleyball and football. He is hemodynamically stable. A chest X-ray shows a small pneumothorax less than 2 cm, 3 cm depending on the guideline referred. Okay, so what is the appropriate next step? Observe and repeat X-ray in 4 to 6 hours. If the saturation is slightly low, 90%, the patient should be given oxygen during the 4 to 6 periods observation period. Okay, got it? Okay. A 70-year-old patient with sudden SOB and hyperresonant right lung and reduced air entry. Okay, it's clearly it's pneumothorax. Which investigation most appropriate to confirm the diagnosis? Okay, hyperresonant shortness of breath, reduced lung leg means patient is symptomatic. So which investigation we will do that? EFAS. Okay, initial step, but in that we will do the in emergency scenarios. Chest tube, it's the most accurate. Best, we can say that best. Understood? Unstable patient, tension pneumothorax, treat immediately, no imaging is required. STEM, they only give you SOB, hyperreduced entry. They did not mention hypotension, hypoxia, collapse and instability, so X-ray is the best answer. Remember that if the patient don't have hypotension, hypoxia, collapse or instability, X-ray is the most important answer. So in that case, if the patient has these symptoms, okay, and the patient is vitally stable, then we will do the X-ray, the standard initial test if listed. Otherwise, we will do the ultrasound, e-fast. Okay. A 4-year-old child who recently had upper respiratory tract infection presented with reduced breathing on one side, hyperresonance and decreased breath sounds. Okay, so what is the answer? This one is very confusing question. Okay, it looks like pneumothorax, but I just thought it's a 4-year-old. 4-year-old. And previously had upper respiratory tract infection. I'm still not sure about this answer, but I'm just looking towards this answer. So upper respiratory tract infection, it might be earlier, he might be misdiagnosed, and it's a 4-year-old child, and then it might be the foreign body, because foreign body will present in the same way. Okay, here is the guideline. It's just same like examination, observe and work of breathing, stridor, drooling, asymmetry, chest movement, tracheal deviation, focal wheeze, decrease breath sounds, check for other foreign bodies in ear, nose or throat if child is stable. Okay, so just all the signs, tracheal deviation, asymmetry, chest movement, tracheal wheeze, decrease breath sound, all everything is same actually, and that is why it's so confusing. Normal chest X-ray does not exclude foreign body, as they may not be the sign of ear trapping, and most commonly inhaler jets or radiolucent. Chest X-ray inspiratory expiratory fields are later liquid visitor use. It will help us. Okay, so it will help us actually, but I am not sure. These are the guideline point of view, right? But still, if foreign body. Because the thing is, in the scenario they might ask about the choking or something, but it might be the clue. But another clue which will tell us, okay, it's not upper, it's pneumothorax, because of upper respiratory tract he might cough a lot, and because of cough he will get the primary spontaneous pneumothorax, but we are not sure, right? So in both cases we will do the lateral X-ray, but in case of what a foreign body inhalation, we will do bronchoscopy. Do bronchoscopy. Diagnostic and therapeutic, right? This is a medical emergency, as we already know that a man post motor vehicle accident presents with low blood pressure, low BP, tachycardia, tracheal deviation. Emergency needle decompression, right? It's simple. Okay. Patient with hypotension, distended neck veins where breath sounds were not audible due to subcutaneous emphysema. Diagnosis was pneumothorax, tension pneumothorax. Tracheal deviation away from the affected site. Hypotension, distended neck veins where breath sounds are not audible need to subcutaneous emphysema. Diagnosis was, I think it's wrong. It's not correct. I will check. I will check later. Tracheal deviation away from the affected site, distended neck veins, and hypotension. Hmm. Hypotension. Okay, let's move to the other scenario. A patient presents with stab wound to the chest. Air is heard entering the wound preferentially. Physical signs: sucking chest wound. Management: three-sided reclusive dressing. Uh, Out but not in. Chest tube placement in the separate intercostal way. So I have the guideline. This I put it in the end, so you can see it. Okay, it's an open pneumothorax, sucking chest wound. A patient presents with a stab wound to the chest. Air is heard entering wound preferentially. Physical sign you can see: sucking chest wound. And then initial intervention we will do three-sided occlusive dressing, and then after that we will put the chest tube placement in the separate intercostal, right? A woman with a history of asthma fell from a horse. X-ray shows multiple rib fracture and subcutaneous emphysema, but no pneumothorax is currently visible. She develops rapid shallow breathing. What could be done before proceeding to intubation? Okay, chest tube, right? In the presence of rib emphysema, positive pressure ventilation can rapidly convert into cold injury into tension pneumothorax. A prophylactic chest tube is indicative. Very, 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 very important, as I told you earlier. Okay. Okay, 35-year-old man presents with 12-hour history of left-sided pleuritic chest pain that came on suddenly while having breakfast. Stable, Chest X-ray shows 3 centimeter apical pneumothorax. Patient is stable. What is the most appropriate in management? Observation in emergency department 4 to 6 hours. Okay. Okay. Not just you. Patient is vitally stable as I told you. Recent evidence shifts management towards conservative observation in a stable patient regardless of the size, followed by repeat X-ray in 2 to 4 weeks. 2 weeks as per the guideline which we read. 50-year-old tall that is already we did this. A patient with 15% pneumothorax who is stable and asymptomatic. Stable patient, no need, just to observe. Simple is that. Don't look towards the size. Refracture fly segment, distended neck means low BP, and absent distended leads to right heart failure, right? Low BP, absent breath sounds on one side. What is the initial management? Needle decompression. Needle decompression is a temporary measures for tension pneumothorax to relieve pressure. Chest tube placement is always required immediately afterwards as definitive management. Chest tab wound, decrease BP, tracheal deviation. What is the next step? Needle decompression. Okay, tension pneumothorax. Gold standard investigation for a stable patient with suspected pneumothorax. The gold standard for diagnosis is an erect chest X-ray showing a visible lung edge and absence of lung marking. Gold standard is actually CT scan, okay, but the gold standard initial one we will do the chest X-ray, right? If there is a complication, then we will do that. If the patient has asthma or COPD or cystic fibrosis something, then we will do the chest X-ray. Sorry, CT scan. Okay, this we already. Okay, this is another past question 2025. Ventilator associated patient, a COVID patient who is intubated and deteriorates the next day. What is a common cause? So common cause to consider is barotrauma induced pneumothorax. I also add the guideline actually. So from the guideline I took this table. Value trauma, high tidal volume, low tidal volume. Prevention that we are not giving high tidal volume. Barotrauma, high pressure, so because of the high pressure we will get the what you call the pneumothorax, limit plateau pressure. Atelectotrauma, repeated alveolar collapse reopening, appropriate PEEP. Biotrauma, inflammatory cytokine release, lung protective ventilation. So how we can prevent that? We cannot immediately remove the patient from ventilator. We have to wait, we have to taper off, and then we can remove it. So because of if we will follow that, we will avoid these traumas. Okay, I took it from guideline. Ventilator also include lung injuries associated with increased morbidity and mortality. Complications of ventilatory induced lung injury includes pulmonary edema, barotrauma, worsening hypoxemia resulting in prolongation of mechanical ventilation. Though higher tidal volumes are proved to increase mortality, multi-organ failure resulting from biotrauma is a major contributor. If extensively inflamed and injured areas get fibrous, there is a potential for long-term respiratory disabilities and core pulmonary in survivors. Recurrence infection are also common in fibrous pulmonary tissues. Okay, so we already did these questions. I think it's a yeah, it's the same questions. Okay, it's a differential diagnosis of pneumothorax. A 46-year-old female present with sudden SOB. Her X-ray is normal and breath sounds are clear. So there is no tracheal deviation, nothing. So don't be confused with that what you call pulmonary pneumothorax. We will do the ECG, okay? And we will in pulmonary embolism we might have the history of surgery, recent surgery or something. ECG correct answer for next step to rule out cardiac causes and shows S1, Q2, Q3 and T3. Okay, if the X-ray is clear in a patient with sudden SOB, tachycardia, always consider pulmonary embolism or a small pneumothorax. So these are the same questions. Let's just keep repeating. Okay, if the patient comes to you with pneumothorax as well as hemothorax, what you gonna do it? We will do the chest tube drainage. Okay, percussion hyperresonant dull Initial tool, X-ray. First of all, we have to do the X-ray, and most of the time in bedside we will do the fast scan. Draining sign, if the hemothorax is more than 1500 ml initial draining, then we will do the thoracotomy. Otherwise, we will do initially one is chest drainage. If the patient is vitally not stable. Okay, good. These are the same questions they have been keep asking. Like questions are same. Yeah, here we have a lot of other options in the same scenario: bronchoscopy, CT scan, lateral, chest x-ray, ultrasound. Same questions they have been asking. Yeah, UT dissection, it's not a part of this topic, but it's also a differential diagnosis. Okay, what is this? Actually, the thing is, okay, if the patient, you did the chest tube, you just put the chest tube, right, and then you have to observe the patient. And if you notice that okay, the patient is still not stable, then what is the next step you have to do? Then in that time period, you have to check that okay, the chest tube is fine, it's not blocked, kinked or dislodged, or it's in a wrong position. You have to do the x-ray, right? But if the chest tube is in right location and everything is fine, what if the chest tube is in correct position and patent? Okay, then we have to think, why is the lung still not expanding? Ongoing problem in the pleural space or airway? Key possibilities: persistent air leak, maybe some fistulas, a large lung injury, or ongoing air escape from the lung into the pleural space. Air is continuously leaking, lung cannot re-expand, maybe some trapped air. There might be a lot of questions. And in EC, what do you call e-medicine, they have these questions, so we will get these questions from there. Okay. Okay, so we have to differentiate between pneumothorax and pulmonary contusion. That is very, very, very important. Pneumothorax, air in the pleural space, hemothorax, blood in the pleural space, and pulmonary contusion, bruising, bleeding in the lung parenchyma, right? Mechanism of pneumothorax, we already know that. Hemothorax, vessel injury, bleeding into the pleural space, and pulmonary condition because of the blunt trauma and alveolar hemorrhage is there. Onset of hemothorax will present immediate sudden hemothorax as well, but pulmonary condition, they might delay 6 to 24 hours. Remember that. Breath sounds absent in both pneumothorax and hemothorax, uh, and also in pulmonary condition, but normally normal initially. Okay, that is very, very, very important. Percussion, hyper resonant in pneumothorax and dull in hemothorax, because it's a liquid, it should be dull. But in ear we have hyper resonant. Okay, tracheal shift possible if massive and rare. Okay, X-ray finding, pleural line, no lung markings, white out, fluid level, right? Fluid looks like white, and in X-ray we will see the black in pneumothorax. Patchy infiltrates, consolidations. Ultrasound absent lung sliding, as I told you, fluid in the pleural space, B lines and consolidation. Chest tube, air and small fluid, then we will do the chest tube. Blood more than 15, we will do the chest tube. Usually not required. Key danger, knee tension pneumothorax, hemorrhagic shock, respiratory failure in pulmonary contusion. Needle thoracostomy, we will do the needle drainage, blood, spotting oxygen and ventilation in pulmonary contusion. Okay, hyperresonant ear, treat stable chest tube, treat stable, unstable. Okay, stable patient, we will not do the chest tube, right? Observation, observation, and unstable, needle decompression first. Hemothorax, dull percussion, blood, chest tube, Drain massive hemothorax due initial drain is more than 1500 ml or more than 200 ml per hour ongoing bleeding per hour, then we have to do the surgical intervention, right? That is thoracostomy. Okay, pulmonary condition, no need to read anything. Okay. Hyperresonant pneumothorax, dull hemothorax, normal percussion but hypoxia worsening contusion. Okay, pneumothorax was foreign body. Very important. Older children, adolescents, mostly less than 4 years. Trauma, spontaneous, sudden chest pain, breathlessness, choking, coughing episodes may be unwitnessed. Onset usually sudden or delayed days and weeks later. Air enters pleural space, object blocks airway. Breath sounds absent or vocal wheeze. Hyperresonant may be normal or hyperresonant. Okay. Affected, reduce on affected side, asymmetrical. Chest movements are asymmetrical. Reduce on affected side, chest movement. Okay. But here it's asymmetrical. Wheeze absent, persistent vocal wheeze. Remember that it might help us in the scenario. Chest pain common, usually absent. Chest pain absent. Remember that. Coughing less prominent, persistent cough common. Stridor rare. If larynx trachea obstruction, then stridor. Tracheal elevation rare, but it might be happening. It might be possible, right? X-ray may be normal. In that pleural line, absent lung marking. X-ray clues collapsed lung, air trapping, hyperinflation collapse. Definitive observation, just to bronchoscopic removal. Okay. Three-year-old calf wheeze, unilateral decrease air entry. Ask, did they choke while eating or playing? If yes, foreign body aspiration. Okay. Child unilateral hyperresonance can be either pneumothorax or can be foreign body. Air is trapped inside the lung, obstructive emphysema and pleural space. Okay, young child persistent unilateral wheeze after eating or playing, foreign body until proven otherwise. Chest X-ray is an investigation choice for suspecting pneumothorax following central venous catheter insertion. So here I just add all the questions from what you called our e-medici. Okay. So we just quickly go through the e-medici questions. Here is our e-medici. Okay. Okay, let's read that from the file actually, because something is wrong. Okay, so in e-medici they're asking the simple questions, like not even a single question. So I just add the tricky question which will I'm actually fail to answer. Okay, so I add these questions here. So we will do quickly from the file, this file. Okay, so okay, so it's an e-medici question. Chest X-ray is the investigation choice for suspected pneumothorax following central venous catheter insertion. Remember that. Prompt imaging is essential to confirm diagnosis and guide management in patient with acute respiratory distress after central line placement. Other investigations may be indicated depending on clinical suspicion but should not delay immediate assessment for pneumothorax. Young patient has spontaneous primary pneumothorax given he is a non-smoker and healthy, has no underlying lung disease. The gold standard management is this patient is observation for 4 hours, then discharge will repeat, check stay and outpatient follow up in 2 weeks to check for resolution of pneumothorax. The patient should be given safety netting advice to represent to medical attention earlier if symptoms worsen. So everything is actually same as we discussed. Okay, 26-year-old woman, emergency department, has treated for gallstone pancreatitis for 1 week ago. Develops acute respiratory distress syndrome requiring mechanical ventilation. After initial improvement, she has acutely deteriorating. Pulse rate high, blood pressure low. Okay, it's an emergency. Saturation is dropped. JVP is elevated. Okay. Chest examination reveals decreased breath sounds on right side with tracheal deviation to the left. Peak inspiratory pressures are elevated on the ventilator. Okay. So they are asking most appropriate immediate management. IV needle thoracostomy. Okay. You understand that why it's that because of the that they did the procedure what you called mechanical ventilation. She's on mechanical ventilation, right? Okay, tension pneumothorax is characterized by progressive accumulation of air in the pleural space with mediastinal shift causing cardiovascular collapse. Clinical features of tension pneumothorax include unilateral decreased breath sounds, tracheal elevation, and hypoxia and shock. Immediate needle decompression is required for tension pneumothorax in unstable patient, followed by definitive chest tube insertion. Okay, so the next scenario is a 45-year-old man, right-sided pleuritic chest pain. Okay, active smoker, 5 year back, examination, pleuritic chest pain. Okay, after bouts of coughing. So patient don't have any COPD anything. So vitally the patient is stable. Vitally he is stable. Chest X-ray shows pleural line 0.5 centimeter for chest wall edge on the right side. The patient has been in emergency for 2 hours and is now symptom free. Which of the following is most appropriate management? Definitely 4 hours we have to wait. Not so observe for 4 hours. That's the answer. That's a chest X-ray. As you can see, a very mild recall pneumothorax. These here you can see. Okay, this question is like beyond my expectation. A 69-year-old man is brought to ER department by ambulance from a scene of motor vehicle crash. Upon arrival, the team has performed a primary survey with the necessary intervention and endotracheal tube was inserted due to Glasgow coma scale of 7. Patient is otherwise stable. One of the nurse become concerned about the patient face, temporarily stop medicine and ask for an urgent review. As the DG interns start to undertake their review of the patient, they notice crepitus on palpation of the patient's eyelid and forehead, neck. A photograph of patient is shown. So it looks like emphysema, right? Which is the following most likely explanation of physical sign visible in the photograph. So it's pneumothorax. The patient has gross periorbital swelling. Crepitus noticed on palpation of the face. This is most likely to be ear in the subcutaneous tissue tracking from a pneumothorax. The crepitus that is felt on palpation is termed as subcutaneous emphysema, while air traveling up so far in subcutaneous tissue would not be a common feature of pneumothorax. Subcutaneous emphysema can often be felt in the neck, and so extension up to the eyelids is not uncommon. Even a small pneumothorax can produce this clinical picture and can easily be missed on these circumstances. In this patient, observing this finding should prompt the clinician to continue their assessment with the focus on vital signs and assessment of thorax, including oscillation, finding percussion of hyperresonance and tracheal deviation. Okay. Okay, that is the most important thing. In all these scenarios, we already discussed that. Okay, and this scenario, patient has hemothorax as well as pneumothorax, as you can see. Okay, and this is fluid. If the patient is stable, no need to do anything. If the patient is not stable, then we have to do that. Pneumothorax. Okay. So these are the emergency question, but we already discussed every single question already. Okay, this is another pneumothorax. Pneumothorax very clear. Okay, so that is all about the pneumothorax. Okay, so what you're gonna do this, remember this chart again and again. Patient is stable, no need to do anything. If the patient, just observation 4 hours. If the patient is clinically deteriorating, whatever the size of the pneumothorax, you have to do the intervention. Okay, thank you so much.